right, so today we're going to do chapter 46, which is sexual reproduction. So this is basically going to go over pregnancy, labor, postpartum, birth control, and things like that. So on your SLO, by the end of the class, you'll be able to plan nursing care, to administer medications in pregnancy, labor, and delivery. Examine the use, action, side effects, nursing interventions of medications given in postpartums and to newborns. Compare side effects and adverse reactions and nursing interventions for drugs for oral contraception and infertility. And it really shouldn't say oral contraception because we will go over or just plain contraceptions. And then you'll be able to calculate some oxytocin and sulfate doses. Once again, this is chapter 46. We're going to omit menopause. Okay, so a little A&P review. If you don't remember, the hypothalamus secretes the gonadotropin releasing hormone. That hormone stimulates the pituitary to stimulate the FSH, LH, and that helps the ovary to causes immature ovarian follicles to begin to develop, and that starts ovulation. And then you'll have another cycle for your uterine cycle, which is your menstrual cycle. Okay, so the rise and fall of these hormones causes ovulation and a menstrual cycle. Okay, so estrogen is secreted by the ovarian follicles. It's responsible for the maturation of sex organs and secondary sex characteristics in women. Progesterones are secreted by the corpus luteum. Usually progesterone is like the most common of the progestins. It prepares the endometrium for implantation. The endometrium is the inside of the uterus. It's the lining within the uterus, so it prepares it and thickens it so that the implantation can occur and it's not going to fall off. Okay, so high progesterone and estrogen levels are in the final third of the uterine cycle. But that's how the body prepares ovulation and prepares your body to become pregnant. So we use synthetic hormones to prevent pregnancy. That's mainly what they're used for. Most is a combination of estrogen and progesterone. There is a progesterone only, and then there's also some like long-acting ones. Before we get into this, I just want to say that the PowerPoint that was given from the book was very lacking in actual information. So a lot of this is just going to look just like your drug cabinet. And I apologize, but I don't apologize. So hopefully it sticks better. I'm not sure. All right. So there's 4 different phases for combo birth control. So the estradiol and the progesterone. Okay. There's 4 types. There's monophasic, biphasic, triphasic, quadphasic. So monophasic is mono, 1, a constant dose of estrogen and progestin. Okay. Biphasic, the estrogen and is constant throughout, but the progestin increases towards the end of the cycle. Okay, so it's 2. So you have basically 2 doses of medication. So that's why it's got that ethyl estradiol 10 and the norethindrone 1. Okay, so it will increase and decrease in both in the cycle of pills. And sometimes there are different colors when you get the foil packet. The triphasic means both estrogen and progesterone differ in each line. Okay, so that means that there's like multiple different formulations of each. So that's why there's multiple different numbers behind those. Okay, the one thing that we need to, in case you've never taken birth control before, when you get your foil packet, it has about 4 lines of pills. Okay, and sometimes they're all 4 different colors, sometimes they're all one color, and then the last line's a different color. The last line is placebo pills. They're just sugar pills. They don't have to take them if you don't want to. You do recommend that they do take them because it is so important when you take birth control that you take it at the same time every day, or it's not effective. Okay, so if you go a week without remembering to take your pill, it's harder to keep up with taking next month. Okay, so that's why they give you the week of sugar pills. And the reason they do that also is because That's how your cycle in your body goes, because your body is slowly giving all these hormones, and it's preparing the uterus, and then as it drops off because no implantation occurs, that's why you get your menstrual cycle. And so it has to shed everything it just did. So that is why it has a week of drop. So you'll start the sugar pills, and within a couple days you'll usually get your period, because you've went from having this continuous or constant dose of hormones, and then now you have nothing. Okay. The most important thing to remember is that all of them have estradiol, and they all contain norgestimate, norgestrone, dydrospirinone, some kind. They look all similar. Okay, so we're not gonna be able to figure them out, but the important thing is that it doesn't matter, because they all have the same side effects. Okay, they all have the same things. It's just how it works different. If it were me and I was going to ask you a question about the differences, I would use a mono, bi, or tri behind it, because there's no way you're going to remember all these. Okay. But the most important thing is that estrogen and progesterone, estrogen is so deadly. Okay. And that is why a lot of people don't like to take estrogen products. Okay. And I'm one of them. I think that hormonal birth control makes me have all of these symptoms, and I don't want them. And I don't think anyone should have to if they don't want to. Okay. Because you have a really high chance of having a clot, a thromboembolism. Okay. You usually get the weight gain, you get headaches. Sometimes you get depression. That's what I would get, especially if I had a low dose of estrogen. It would make me super depressed. Okay. So I needed more estrogen, and I couldn't figure out which one would work for me. And so I just quit. My body figured it out itself. Okay. It can give you cervical cancer. It can give you breast cancer. Okay. You can have hyperglycemia, and then what goes along with that is a vaginal the candidiasis, which is a yeast infection. Okay. If I have high blood sugar, a lot of times you'll get the yeast infection. Okay. High blood pressure, hirsutism, which is when you have male-like hair growth. So you'll grow a mustache, you may grow a beard, you may grow hair everywhere. Okay. Lupus exacerbations, menstrual irregularities, which is like breakthrough bleeding. So you may bleed in the middle of the month and you don't know why. Migraines, nausea, and then it is also a teratogenic, so it's not safe for pregnancy, obviously. So we need to tell them what a clot looks like. We need to monitor for clots. Okay. You need to tell them about depression, monitor for depression, teach them not to smoke, because that will increase your risk of having a clot. Okay. The quadphasic, the fourth, which is the only one of the quadphasics, it is usually used to treat heavy menstrual bleeding. Okay. And then you need to teach them about monthly self-breast exams. Super important. Okay. Because we don't want them to get cancer, especially if they have a history of breast cancer in the family. If they've had cancer themselves, if they have HPV, we need to check for. You need to stress their cervical exams and their pap smears to check for cervical cancer. Okay. All right. So progestin only. This is so it doesn't have any estrogen. There's only one of them. It's norethindrone. Okay. It causes a thick, viscous mucus at the entrance of the uterus. So right above the cervix is going to create this thick mucus so that the sperm can't get through, and then it won't implant. Okay. Once again, the risks are less because you don't have estrogen. But you do still have a risk for clots, hyperglycemia, you have high blood pressure, hirsutism, breast milk reduction. So tend to be less effective though. So the estrogen does increase the efficacy of the birth control, but it does tend to be less effective. But you have a less tendency of a thromboembolic event, and you have no effects on breast cancer, which is great. Once again, teach them not to smoke, monitor for side effects and clots and things like that. Okay. So then we have our long-acting reversible contraceptives. So the first one is Depo-Provera is used is very common. It can also be called medroxyprogesterone, which we'll get to in the end what it's called. So it's a IM injection or sub-Q injection every 3 months. Okay. You still can have the hirsutism and the weight gain. I hear those are like the most common side effects to me. I feel like a lot of people who got the depot shot, they would have the abnormal hair growth and the weight changes. A lot of times, most birth control makes you gain weight. So anxiety, depression, stroke, thromboembolism. So it cannot be reversed following the injection, but if you wait 3 months, then you're don't have any kind of coverage. The most important thing I feel like most women or people who are taking this kind of medication don't know is that it says it can take up to 12 months to restore fertility. And I know a lot of people who took this at young ages who have huge problems with infertility and they still haven't gotten it back. Okay. So if this is a young person, you need to tell them, because if that's something that they want, if they want to have children, if they want to have children young, especially, you need to tell them before you give it to them, because I wouldn't want to take it if it were me. Okay. Once again, no smoking, monitor for depression and clots. Okay. The Nexplanon is a little implant, usually on the upper inner arm. It can provide 3 years of protection. It can again cause weight gain, headache, depression, thromboembolism, and the rod can migrate. Okay, I worked in interventional radiology, and we had to take these out when they couldn't take them out in office. Okay, so when it had moved somewhere else and they couldn't find it, and we had to go get it. It's a simple procedure in office. They just numb you up a little slice. It goes right under the skin, maybe 1 stitch, and then you're good. They probably even dermabond it, which is just glue. But they need to check for the placement. Okay, they may not have a period at all, and teach them to feel for the implant every month and monitor for depressions and clots. So the transdermal patch is great for people who cannot remember to take the pill. Okay, these are great options for people who can't remember to take the pill every day. So the patch has the same action, but it's changed every 7 days for 3 weeks, and then you have a week of no patch. Okay, and when it says same action, it means that it has the same. It's still got estrogen and the progesterone. Okay, so it's got a constant dose for 3 weeks, and then you take the patch off for a week, and then you get your period. Okay. So once again, headache, depression, irregular bleeding, and you could have a clot. There's a black box warning for smoking, especially for those over 35. It is contraindicated for anyone who's got a BMI over 30, because for both of these reasons, you have an increased risk of thrombotic event, and it decreases the effectiveness because it's on the transdermal. So it's on top of the skin. So they usually do it like on the hip, on the arm. You need to teach them the same kinds of things. Don't put it over a very hairy area. Don't put it on somewhere where you've got an open wound. Common things that we'd already know how to teach people how to use a patch. But when you have someone that is obese, you have a very increased adipose tissue. So the patch is not effective because it has to go through all the adipose tissue to be absorbed. And that is why it is not very reliable. Okay. The Nuba ring or the Annovera is a little ring. It's like silicone. It's very flexible. It's once again, same action. It's a 2 to 3 inch ring. So it's about this big, and you just insert it vaginally for 3 weeks. Most important thing is to teach them how to use it. Okay. So the Annovera is it's same ring forever. It's just, I'm guessing they change it out every 6 months, every year. You wash it and then reinsert it. Okay. So you leave the vaginal ring in for 3 weeks, and then you have a week without. Okay. Super important to tell them that it goes vaginally. Okay. I saw someone wear it on their wrist like a bracelet. It's not going to work that way. Okay. It's got to go inside. And so you need to teach them what it feels like, what it looks like when it's in the right place. Okay. Thromboembolism, headache, depression. Once again, there's a black box warning for smoking, and over 35 years old, increased risk of thrombotic event. So you need to monitor for clots, monitor for depression. So then we get into IUDs. Okay. So these are hormonal IUDs. They do have a non-hormonal IUD as well. It's called a copper IUD. We'll get into that. So IUDs, same action. It's got estrogen in it as well. It's a T-shaped device. It's inserted into the uterus. It is ridiculously painful to get it put in and to take it out, okay? And no one believes you, but it is. They don't numb you, they just shove it in there, okay? It's not fun. I know a lot of people that pass out or don't like it, okay? The most important thing is that it's a T-shaped, okay? So it's a little piece of plastic. It's very flexible. And on the end, it's got these long strings, okay? So what they do is they insert a large cotton swab through the cervix. They usually want you to go around your period so that your cervix is slightly open and so it doesn't hurt as much. Just important to tell someone that. So they insert the cotton swab, and so then they can see how far up, how tall the uterus is. They measure it, they pull it out, and so they know how far to insert the IUD. So then they have like this implant device. It's kind of like a catheter, like an IV catheter. So they have it set up where it's like one straight line. And so when they put it in and they increase like a tampon, they push in the applicator, it'll fling the arms out and then it's there. Then you have the strings, and then they cut the strings about midway in the vagina. The important thing about the strings is that you have to check your strings monthly to be sure it doesn't migrate, because it can migrate outside the uterus. It can implant itself into the uterus. There's lots of problems that can happen with these. The non-hormonal is not here because it's not really a medication, but it's a piece of copper that constantly irritates the inside of the uterus, and so that implantation cannot occur. A lot of people have, of course, you can have the IUD can migrate the headache, depression, thromboembolism. So monitor for clots and depressions. With the copper IUD, you really need to have a discussion. I feel like with both IUDs, you need to talk to them about how it works and why it works. There's lots of things that can go wrong. With a copper IUD, you do have an increased risk of bleeding, especially during your period. Like the cramps are out of this world. Speaking from personal use, I've had one before and it made my periods super, super heavy, super, super painful. Okay, like the first day of my cycle, I was on the floor the whole day. I couldn't move. Okay, and extreme bleeding, like I almost passed out at work because I was bleeding so heavily. And then I talked to a friend who took it, and she's like, oh, I have no problems, it's whatever, so everyone's different. All of these birth controls are different and they affect you differently, okay? And then we have the Seasonique, which is an estrogen-based birth control, but you take it for 84 days. So it's called a seasonal birth control because you have a period 4 times a year. Seasons, like the 4 seasons, okay? So you have to definitely monitor for thromboembolism because we're taking estrogen for 84 days straight. Weight gain, headache, depression. With all of these birth controls, women have to figure out what's good for them. Like none of these are going to work the same for everybody. So you may have to try a different couple of them to get it right, okay? So the estradiol and norethindrone, okay? This is a PO pill, as most of the oral contraceptives are. They prevent pregnancy. They can also be used to help clear up acne. They're for endometriosis, hypermenorrhea, which is when you have a dysfunctional bleeding, like you have more bleeding than normal, and then dysfunctional uterine bleeding. So it inhibits FSH and LH release, which inhibits ovulation. So one important thing to teach them about when they start a birth control, they are not effective for 1 month, okay? So though it starts working in 30 to 60 minutes and your periods will regulate themselves, the contraception part does not happen for 1 month, okay? That's important to tell someone. So adverse effects: nausea, breast tenderness, weight gain, breakthrough bleeding, edema, vision changes, gallbladder disease, nausea, abdominal cramps, urinary function changes, dysmenorrhea, which is abnormal bleeding or very painful bleeding, menstrual cycles, breast fullness, fatigue, skin rash, acne, headaches, vaginal candidiasis, photosensitivity, hypertension, thrombotic event, black box warning. As for all estrogen products, with smoking, increases the risk of a cardiovascular adverse effect like a heart attack, okay, like a stroke, which increases more when they're over 35 and you have more than 15 cigarettes a day, okay? So drugs that it interacts with are tranexamic acid, which increases your thromboembolic event, rifampin, antibiotics, because we know that antibiotics lower the contraception, lower the efficacy. Barbiturates, anticonvulsants, protease inhibitors, antifungals, decrease efficacy, decrease effects of warfarin, heparin, and anticoagulants. So no St. John's wort, and there's no overdose treatment. So contraindications would be history of thrombotic events, strokes, coronary artery disease, liver tumors, any kind of breast carcinoma, endometrium or estrogen dependent tumors, abnormal uterine bleeding, jaundice, or pregnancy. Must be taken exactly as directed at the same time every day. You have to stop it if you become pregnant. Teach them not to smoke, monitor for clots, teach patients to take meds at the same time daily. Nighttime administration reduces nausea and headaches. I definitely agree with that. That is very true. Not effective until 1 month of therapy. Birth control does not affect against STIs or HIV. And they need to perform routine breast exams, okay? One thing I forgot to mention was with the IUDs, if you have an abnormal shaped uterus, you cannot have an IUD. Okay, I had a friend who had a heart-shaped uterus. You get them a heart-shaped uterus, and she even had a septum. So she basically has 2 uteruses. She got the IUD put on one side, she got pregnant on this side. Okay, so if you have an abnormal shaped uterus, you cannot have an IUD. And usually you don't really know until you know. Okay, but if you do know, do not advise this. All right. So emergency contraception, Plan B. Everyone knows what Plan B is. So you can take it within 72 hours after unprotected sex. Plan B can have 2 doses or 1 dose. It just depends on the dosage of the levonorgestrel. So if it's just the Plan B, the plain levonorgestrel, you take it 12 hours apart. If it's the 1 step, you can take it 120 hours after unprotected sex, and it's a single dose. Okay, but the most important thing to remember about these, the levonorgestrel, is that it prevents ovulation and implantation. It does not induce abortions. This is not an anti-abortion drug. This is not an abortion drug, okay? This does not induce abortions. It causes the uterus to basically, it prevents ovulation, and basically it induces your period. So it causes the uterine lining to shed, and it does not work if implantation has already occurred, okay? I know people who have taken Plan B and still become pregnant, okay? If implantation has already occurred, it's too late. So this is definitely something you need to tell someone if they're taking this to prevent, obviously, getting pregnant. So administer as soon as possible, because once contraception happens, doesn't work. Ulipristal or Ella is a prescription mixed with progesterone agonist antagonist. Is effective for up to 5 days after unprotected sex. So then we have our medications that can cause abortions, and these are used rarely. Okay, this is for when if you have a implantation in the wrong place, the fetus isn't viable, things like that. So misoprostol and mifepristone are used. You have to monitor, you really need to monitor these patients while they're taking it. It really should not be taken at home, okay? Monitor, because you can have a uterine laceration, you can have a uterine rupture, or you can start hemorrhaging, okay? These are not things to be played with. These are very serious medications that really need to be done under a doctor's care if we had these available. Okay, so dysfunctional uterine bleeding. So this is hemorrhaging that can occur on an abnormal basis. It's a common reason for hysterectomy. If you have bleeding, so if you've gone through menopause and then randomly you have bleeding, that is a sign of cancer, and you need to go to the OBGYN. It is super important to teach people who have gone through menopause that they should still go to the OBGYN. If you've had a hysterectomy, a total hysterectomy even, you should still go to the OBGYN, okay? There's so many times that older women have menopause, they never go to the OBGYN again, and then they have uterine, ovarian, or cervical cancer. They don't know because they haven't been getting their pap smears and their yearly exams from their physician. Okay, so this is a variety of causes, often an imbalance between estrogen and progesterone. So estrogen can cause proliferation of the endometrium. Progesterone can limit and stabilizes the endometrial growth. So these are conjugated estrogens followed by medroxyprogesterone. NSAIDs also help, especially with the pain. Okay, NSAIDs are ibuprofen, Toradol, great for menstrual cramps and menstrual pain because they help relax the uterine muscle. So medroxyprogesterone or the Depo-Provera, Depo sub-Q Provera or Provera, they're all called the same thing. So when we were talking about the Depo shot earlier, this is what it is, okay? So it's IM-PO sub-Q. You can use it for endometriosis, amenorrhea, which is no menstrual, you don't have a period, uterine bleeding, and contraception. Synthetic progestin with prolonged duration of action inhibits the effects of estrogen on the uterus. You can have breast tenderness, breakthrough bleeding, menstrual irregularities, weight gain, depression, headache, hypertension, nausea, vomiting, dysmenorrhea, vaginal candiditis, increased risk of thrombotic event. If you're over 65, you have an increased risk of dementia and bone mineral density loss, okay? Black box warning when combined with conjugated estrogens and may increase the risks of stroke, DVT, heart attack, pulmonary embolus, or invasive breast cancer. We want to avoid drugs that have serum levels decreased by carbazine, that is a seizure med, barbiturates, primidone, rifampin, rifabutin, topiramate, azole antifungals, nicardipine, and protease inhibitors increase the effects of the medication. Avoid St. John's wort. There's no overdose treatment. The contraindications: pregnancy, lactation, having a breast carcinoma or having a suspected breast carcinoma, history of thrombotic disease, hepatic impairment, undiagnosed vaginal bleeding, because like I said, that could be cancer and you don't know yet, depression. So if you're going to give it PO, give it with meals to avoid the nausea, vomiting, and gastric distress. Monitor for depression, liver function, and clots. Teach to perform regular self-breast exams. Amenorrhea is possible with prolonged use, which means you won't have a period. Encourage calcium and vitamin D supplements to prevent the bone mineral density loss, and advise the shot is every 3 months. And if you miss a dose, you are not covered for contraception, okay? If you're a month late, if you're weeks late, it does not work, okay? All right. So labor and breastfeeding. So we use stimulate uterine contractions and promote induction of labor. Oxytocics stimulate the uterine contractions and promote the induction of labor. Tocolytics inhibit uterine contractions during premature labor, okay? So the oxy induce, the toco prevent. With oxytocics, so it's a natural hormone. It causes more milk to be released. It can stimulate uterine contractions to induce labor. When they say it's a natural hormone, you have oxytocin in your body already. It's stimulated when you start to breastfeed or when you feel happy. It's supposed to be a happier drug. So this is just a synthetic form of it. It's a natural hormone. So you can give it IV or IM. It's to induce labor. It reduces hemorrhage. For incomplete or inevitable abortion, it can, like I said, it produces labor, uterine contractions, so it can help with incomplete or inevitable abortions. So it mimics oxytocin hormone in the posterior pituitary gland to cause uterine contractions. It's very fast onset. So you can have rapid, painful uterine contractions. That's definitely true. It can make your contractions stronger and more painful. Fetal tachycardia, fetal dysrhythmias, and fetal intracranial hemorrhage. You can have maternal uterine rupture. You can have seizures, coma. This is all for the mom. And risk of rupture increases if you've had more than 5 babies. There is a black box warning that is not indicated for elective induction. There has to be a medical reason to get oxytocin. You can't just decide I want my baby to be born on the 13th, so that's when I'm going to have it. Vasoconstrictors are not advised because of severe hypertension. There's no food, but treatment overdose causes strong uterine contractions. Stop the oxytocin and the uterine contractions will stop as well or lessen. So contraindications when you are antepartum, so that's after you've had the baby. No, it's not. I'm so sorry. Sorry, antepartum is the time between becoming pregnant and labor. Sorry about that. So we do not use it if there's significant cephalopelvic disproportion. So basically the head of the fetus is bigger than the hips of the mother or the pregnant patient, because we're not going to have a vaginal birth in that case. So this is not indicated. We will just perform a C-section. Unfavorable fetal position. So if the baby is transverse or in a not or breech, we don't give them oxytocin because we don't want to induce labor and bring the baby down if they're not going to turn and be in the right position. OB emergencies, fetal distress is a big one. If the baby is already showing this dysrhythmia, tachycardia, things like that, we're not going to give them oxytocin because it can stress them out more. Especially when delivery is not imminent. Adequate uterine activity fails to progress. So if they've been in labor for a long time, the oxytocin, if they've had it, or if they're doing this natural and it's not progressing, they're usually going to do a C-section anyway, so there's no reason to start the oxytocin. Hyperactive or hypertonic uterus. So hyperactive uterus, my uterus is already having rapid, painful contractions, or hypertonic, which means the tonic means no tone. So the increased tone of my uterus. Vaginal delivery is contraindicated. So you have a cervical carcinoma, you have an active genital herpes, you have a total placenta previa, a vasa previa, the umbilical cord is presented, or a prolapsed cord. You're not having a vaginal delivery anyway. We don't need oxytocin. We'll just take you to get a C-section, okay? So dilute 10 units of oxytocin in 1,000 milliliters of IV fluid before administration. Postpartum administration may add up to 40 units in a milliliter bag. They do give this immediately postpartum. Sometimes IM, sometimes IV, depending on how you've had it previously, the case by case. And this helps prevent postpartum hemorrhage. Allergic reactions increase with IV injection and IM. If your patient's getting oxytocin, it's a 1-to-1 monitoring. You don't have any other patients, you're my only patient, okay? So you monitor their INO, you monitor their uterine contractions. Are they too strong? Are they too fast? You monitor the heart rate, blood pressure of the patient and of the fetus, okay? You can't monitor their blood pressure, but you can monitor their heart rate. So if contractions occur less than 2 minutes apart, so 90 seconds apart, less than 2 minutes, okay? Less than 2 minutes apart, exceed 50 milligrams of mercury, which means it's very strong contraction, or if they last longer than 90 seconds, stop the infusion, turn them on their side, usually the left, call the doctor. It's too much, okay? You've had too much oxytocin. It's an emergency. We have to stop the oxytocin, okay? So that is oxytocin. There are other medications given during labor. Methyl lergobenine, or it's much, the trade names are so much easier to say. But this medication directly stimulates smooth muscle shortening, okay? So smooth muscle shortening means contractions, okay? Methergin. Methergin is the trade name. You will hear Methergin a lot, okay? That is a generic, but it's Methergin. So you can have nausea, vomiting, obviously uterine cramping, shock, severe hypertension, and dysrhythmias. You have to monitor blood pressure and the heart rate and the uterine response. Are my cramps too much? Is my blood pressure too high? Okay. Wait 12 hours after the last dose to breastfeed, or you can pump and dump, okay? Which means pump the breast milk out and throw it away. Monitor their blood pressure prior to administration. That's a big one, okay? I'm so sorry. The prostaglandins, which is the carboprost or the dinoprostone. These are super important too. So these carboprost controls serious postpartum hemorrhage, and the dinoprostone promotes cervical ripening and dilation. As you'll learn in OB, when the cervix ripens, that's called effacement. So that's how it thins, and the dilation. So you have to have both of them to be ready to give birth. If if the cervix is super thick, the baby, it's not gonna dilate very well, and it's gonna be super painful. So we want it to be dilated and for the cervix to be effaced, okay? EFFACE, effaced, or effacement, efface, okay? Nausea, vomiting, diarrhea, this is what they use a lot of times, is given intravaginally or rectally. And so they give it to you along with the oxytocin to induce labor. So this one's going to dilate you, one's going to cause the uterine contractions that will hopefully jumpstart your labor. Nausea, vomiting, diarrhea, headache, uterine cramping, uterine lacerations, or perforation due to intense contractions. So monitor their uterine contractions, monitor their blood pressure, heart rate, and for cervical changes, because we want to make sure it was effective. And when you feel a cervix, that's how you know, like, so when they do the cervical checks, you know if it's dilated, if it's very thin. They'll explain what that is in OB. Okay, so now we have our tocolytics. So our things we use for preterm labor, we don't want them to go into labor yet, okay? Hydroxyprogesterone relaxes smooth muscle, causes uterine contractions to decrease. You can have injection site pain, swelling, urticaria, thromboembolic disorders, depression. Monitor INO, monitor for fluid volume excess with the swelling, and that's not very good. It can lead to, eclampsia and things like that. Monitor their blood sugar, monitor their hepatic function, stress the importance of not missing any doses. If they tell you, however they tell you to take it, you need to make sure you take it, or it's not gonna work and you're gonna go into labor. Mag sulfate. That is a huge drug they use all the time in labor and delivery, okay? So it relaxes smooth muscle, causing uterine contractions to decrease. So basically the side effects are magnesium toxicity. I'm not sure if you got this in fluid electrolytes, not fluid electrolytes, last semester in Pharm, but you need to make sure you go look, or in the first semester. One of the semesters you should have had magnesium sulfate. There was a box in the book. Read it, okay? So mag is a drag that's super, super popular in OB. They use it all the time to help with preeclampsia, eclampsia, for preterm labor, okay? So mag is a drag. So if I have too much, I'm gonna start having the flushing, sweating. So I'll have like the red face. They'll start sweating, muscle weakness, which is when, so all my muscles become like, I have the hyporeflexia, okay? So all my muscles relax way too much. I can go into complete heart block, which is deadly, and respiratory paralysis, which is also deadly, right? I can stop breathing. If you have someone that's taking mag, it is a super dangerous drug because they have to use it for such a long term and for higher doses. Sorry. So you need to have calcium gluconate available. If you know someone's going into magnesium toxicity, you need to give them calcium gluconate. So this prevents the cardiac side effects, the cardiac toxicity that goes along with magnesium side effect toxicity. So it's super important to get them, have it available, and give it if it needed. Test their reflexes, because if they're starting to be, if they have a chart usually that teaches you how strong they are or how weak they are, and you have to, you know, titrate between to keep them within a certain amount. Monitor their mag levels, monitor their INO, their renal function, because that's how the magnesium is excreted, and monitor for fetal mag toxicity, okay? So nifedipine, which is a calcium channel blocker, it blocks the influx of calcium influx, but it decreases smooth muscle tone, so it will relax the uterus. So side effects: flushing, sweating, muscle weakness, same ones, okay? We need to monitor their blood pressure and heart rate because this is a calcium channel blocker. Terbutaline is a huge one they also use in OB. They use it all the time. It relaxes smooth muscle in the myometrium, the bronchial tree, and blood vessels, okay? So you can have nervousness, tremors, drowsiness, bronchoconstriction, because I've just relaxed all the bronchial tree. It could work too well. Now I've got it too relaxed or too small. Dysrhythmias, altered maternal or fetal heart rate, okay? So it can affect the fetus. Black box warning: do not use for more than 48 to 72 hours during pregnancy. This is not used in like super preterm labor. This is used if you're in preterm labor and still viable. So monitor their heart rate, monitor their blood pressure, monitor their respiratory status. Contraindicated if you have a dysrhythmia or cardiovascular disease, because those two things are going to put you into those lethal dysrhythmias, and we don't want that. Okay. All right, so now we have miscellaneous care. These things are not directly from your book. This is from practice and from your OB class, okay? So aspirin. If you get something that contraindicates, contradicts what I'm saying, please go by whatever the class says. If the class says don't take aspirin, don't take aspirin. So aspirin used to be that you don't take it till the 3rd trimester. Now my doctor told me to take it starting in the 2nd trimester because they've actually seen that it can prevent preeclampsia, especially among first-time moms and first-time moms and African-American women, okay? Because for some reason, African-American women have an increased risk of preeclampsia. So it's super important that they take a baby aspirin. Okay, that's all it is, just a baby aspirin. Folic acid, multivitamins, and iron are commonly taken throughout pregnancy. Folic acid, multivitamin, or the prenatal vitamins are super important for fetal development. Iron is usually given for anemia caused by pregnancy, because the baby sucks all your good stuff out. Though iron, make sure you know that it does cause constipation and it can cause nausea and vomiting. So remember all that from way many semesters ago. Okay. Rogam, the Rogam injection is given at about 28 weeks pregnant. And it's only given to Rh positive pregnant patients. Rh negative. So I'm O negative. I have to get the shot at 28 weeks. You have to get it no matter what your husband and your partner is, whoever the donor, whatever it is. You need to get it because you can have antibodies towards the baby. So my first child is A positive, like my husband, and I'm O negative. If usually the first pregnancy you have this coverage for your body doesn't recognize the problem, but the second pregnancy is when you have a problem, or the later pregnancies. If the baby is positive and the mom is negative, and this only happens to when the pregnant patient is Rh negative, so A negative, B negative, AB negative, O negative, any of the negatives. If the baby is positive, the maternal body will create these antibodies to, just like when you give the wrong blood type to a person, it can kill them. Pregnant patient, the body will attack the fetus and cause death because it recognizes this as foreign and it's not the right blood type. So the Arogam shot prevents this from happening and prevents the antibodies from even developing. Okay. So it's super, 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 super important to get. Okay. And that's when a lot of times when people have miscarriages or they come in with abnormal uterine bleeding, they test your blood type and they're usually Rh negative. And so they need to get a RhoGAM shot. The Tdap vaccine is also super important because it is given in the 3rd trimester. And the reason they wait till the 3rd trimester, and you get it every pregnancy, no matter if you had a pregnancy 9 months ago and you got pregnant right after that one, you have to get it every pregnancy in the 3rd trimester because it ensures the passive antibodies to the fetus to protect against tetanus, diphtheria, but most importantly, pertussis, okay, which is whooping cough, which is deadly for infants. For constipation, they usually tell you to use bulk forming laxatives. Colace is super helpful as well, which is a stool softener, which is Docalax. I'm sorry, Docusate. Stocusate. Also super important postpartum. So the first time, especially if you have a vaginal birth or a C-section, you've had abdominal surgery and if you've had a vaginal birth, you've had vaginal trauma. Okay, the first bowel movement after having a child is very scary because it almost feels like you're going to have a baby all over again. You have everything, it's sore, it's bleeding, it could be torn. So stool softeners are super important to stress after labor. And if people, they're like, no, I've never had a problem. I've never, I don't care. Take it. It'll just make everything easier. So when you have the bowel movement, it's softer. It doesn't hurt. I remember being so scared for the first bowel movement. Like a lot of patients are super, super, super scared for their first bowel movement after having a baby. The Colace just helps everything. Tell them to avoid castor oil and mineral oil. Okay. For minor pains, they say Tylenol is fine. Avoid ibuprofen until the 3rd trimester. Heartburn, antacids, aluminum hydroxide, magnesium hydroxide, and aluminum hydroxide with simethicone. That's one big drug. That's Mylox extra strength. You can even give them Carafate, but that's a prescription. For nausea and vomiting, everyone's different for nausea and vomiting, the providers wise. I've had some people say that you can take Phenergan. Some people said that you can take Zofran. I know that they're both not super, they're not in a good category. So there's not a lot of medications you can take for nausea and vomiting. So it's provider specific, patient specific. If you have hyperemesis, they're gonna do something totally different. Okay. The fun thing is that vitamin B6, so the doxine, liamine, succinate, and the pyridoxine, which is vitamin B6, actually does help with nausea and vomiting in pregnancy, and it's a vitamin, so it's super, not super harmful to the baby or to the mom. All right, so during labor, for preterm labor, I know we talked about the tocolytics, but we also need to talk about things that if premature labor, there's no way to prevent it. It's happening during labor. So this is given at 24 to 34 weeks, but the baby is mostly viable. Okay, when the fetus is mostly viable. So betamethasone and dexamethasone are given to accelerate lung maturation, which is mature the lungs because they're not usually developed by then. Surfactant development, so it's basically helps improve the surfactant development in the fetus and utero, decreases the incidence and severity of respiratory distress syndrome, increases the survival of the preterm infants. So the effects and benefits usually begin within 24 hours. So if we can give them the tocolytics and the steroids and we wait 24 hours before they have the baby, we will have the best benefits. Okay. So lasts up to 1 week. The goal is to delay delivery for 48 hours to maximize the effect. You can have the side effects are seizures, headache, vertigo, edema, and hypertension. So for pain during labor, they can give you mepedrine, butorphanol, hydromorphone. Those are most commonly given. You need to make sure you have some form of Narcan available though, because if they become too sedated or the baby's in distress, we need to Narcan them. So immediately after delivery, the babies are usually given a vitamin K IM injection. And as I remember from lifespan, that's the vastus lateralis only. Okay, within 1 hour of birth, and it prevents a hemorrhagic disease in newborns. I see a lot of people who decline the vitamin K. That's the patient's choice. I mean, they're the parent, they can decide, but they do give this very commonly. It doesn't really have too much harm to the child. It helps them prevent unknown hemorrhagic disease that you don't know and you can't test for weeks. They also use erythromycin ointment. It's a 1/2-inch strip in the lower conjunctival sac of each eye. 1 hour after delivery is required by law, and it is a prophylactic against eye infections. Usually if you had a precipitous delivery and they had like some kind of active STI or something like that, they'll put the erythromycin and it kind of prevents getting the infection in your eye. Okay, the other thing is surfactant. So now you've had the baby, or you didn't get to wait the 48 hours. It was just preterm labor. We need to get the surfactant into the child now. So it's called baricitant, calfacatant, and poricatant alpha. These are surfactant therapies, okay? So the baby is intubated. So it is given through the ET tube. The head has to be elevated, and you cannot suction within 2 hours of administration. So they need to be in a semi to high Fowler's, okay? And you cannot suction the baby after. So get all the suctioning done before and then give them the medication, okay? Stop the medication, do not give any more. And if the child is dusky, agitated, bradycardic, if their SATs are less than 95 or their CO2 is less than 30. Okay, and also in the surfactants, they are usually stored in the fridge. They need to be warm before you give them. If they're cold, you can agitate the respiratory tract, okay? Before leaving the hospital, if the mother is Rh negative, they need another RhoGAM shot before leaving. And then the infants can get the hepatitis B vaccine before leaving, or they can wait until their first appointment with a doctor. All right, so infertility. The most important thing about this is there's different types. There's dopamine receptor agonists, so that reduces the high levels of prolactin. Ovulation stimulants, so they produce the follicle to mature. Androgenic hormones. So this is an anabolic steroid. It suppresses the FSH and controls control of the endometriosis. Sorry. FSH and LH enhancing drugs. So they promote follicle maturation and ovulation. The gonadotropin analogs agonists. So that suppresses FSH and helps control endometriosis. And then there's the antagonist, so that prevents premature ovulation. So the most important thing is that these are altering your ovulation cycles somehow. So they can have a lot of adverse effects with that. It may lead to early postpartum conception. You just have to monitor for the side effects. There's different types. You have to figure out why they're having the infertility to be able to treat it, okay? So then we have hypoactive sexual desire disorders. So these you can treat with finasteride or bremelanotide. Sorry. The most important thing you need to know with this is it can it does have a black box warning for severe hypotension and syncope if taken with alcohol, and it's contraindicated for hepatic impairments. The mechanism of action isn't even known, but it treats premenopausal women with a hyposexual desire disorder. It can cause dizziness, sleepiness, dry mouth. And this other one is an injection 45 minutes before anticipated sexual activity. You can have nausea and flushing. So now we get into calculations. So we have an important new conversion. So it's called microunits, MU. So microunits, there is 1,000 microunits in 1 unit, okay? So with that knowledge, see if you can figure out this problem. I'm going to give you 3 seconds and then we'll go over it. So I have 10 units of oxytocin added to a liter of D5LR to infuse it 2 microunits a minute. What are you going to set the pump to for milliliters an hour? Okay, so the dimensional analysis on top, if I want milliliters per hour, I'm going to start, that's what I'm looking for. So I have 1,000 milliliters over my 10 units. That's what it said, right? Add 10 units to my 1 liter bag. I have to convert this to microunits, so I throw in my conversion. And I know I have 2 microunits per minute, so I'm going to add that in. And then I need to convert this 1 minute to 60 minutes, so that's why I have this next conversion. You multiply across, divide, 12 mils an hour. For the desired over halved, you have to first convert the units to microunits. So I multiply by 1,000 and I get 10,000 microunits per liter of fluid. So I know it says a lot of times you put your desired microunits, which is the 2 microunits per minute, over my microunits that I have, which is the 10,000, and then you multiply your volume, okay? And that gives you 0.2 milliliters per minute, but I want per hour, so I need to multiply it by 60, and I get 12 milliliters per hour. Confusing? Yes. All right, so now I need to find my microunits per minute. I need to go backwards. I have 10 units of oxytocin in a liter of D5LR. My IV pump is 18 mils an hour. How many microunits per minute are they receiving? Please pause if you need to, okay? So I'm looking for microunits per minute. I started with the minutes on the bottom because I knew I had that, okay? So I have my 18 mils an hour, so my 18 mils per 60 minutes. I have my 10,000 microunits per 1 unit and my 10 units per liter. The reason I did it like this is because for some reason I could not remember how to get the microunits on top. So I started with what's on bottom, okay? So I know I have my 60 minutes over my 18 mils. I know next I need my conversion so that I set this up correct. So I know my microunits on top, which is why I put my 1,000 microunits over my 1 unit. And then I put my 10 units over 1,000 so that my units can cross out. I need my milliliters to cross out as well. So then I'm only left with the microunits over milliliters. I multiply across, divide 3 microunits per minute. So once again, if I'm doing desired over halved, I have to convert my 10 units to microunits, which is 10,000. Okay. So now I have my 10,000 units per ml. So the way you do this, it's different now. It's not desired units over half units, like desired milligrams over half milligrams. It's it's my milliliters an hour over my milliliters that I have. Okay, so that's my 18 mils an hour divided by my 1 liter. Okay, multiplied by 10,000 microunits, and then I get 180 per hour. But I want this per minute, so I'm going to divide by 60 and I get 3. The reason you have to do it like this is because there is no other microunits to put under here because you don't know them. That's what you're searching for. Okay, but I do have 2 milliliters. So I'm going to put them together. This is how I make it make sense in my head, at least. If you have another trick, please put it in the discussion board so everyone else can benefit from this. Okay, so I know I have 2 milliliters and those go together. So I can put this 18 mils an hour on top and my 1,000 milliliters on bottom. That means that they're together and they're going to cross out. So I can multiply by my microunits and I'm left with the microunits per hour, right? Because there's like a per hour right here. So if these cross out, I'm left with my microunits per hour, so I'm good. I know I got it, okay? Just please don't forget the last step of dividing by 60, or you won't get per minute, you'll get it per hour, okay? All right, so now I have magnesium sulfate. It's a 40-gram bag in a 1,000 milliliter bag. It's given 3 grams per hour. How many milliliters per hour are we going to set the pump to? Once again, pause if you need. Here's 3 seconds. All right, so I'm looking for my milliliters per hour. So I put that in front so I know I'm looking for. Once again, I started with my hours on bottom because that's what I knew I had. I had a very good one. Okay, so my 3 grams per hour, I need to cross out the grams. So I have to put my 40 grams over my 1,000 milliliters on top. So then I'm left with the milliliters per hour, multiply across, divide, 75 mils an hour. If I'm doing it the desired over half, once again, I have to put my grams over hours on top because I have 2 grams. See, 1, 2. So I have to put those, the desired grams per hour over what I have grams and then multiply by the volume. And that's my 75 mils an hour. Okay, so that concludes the sexuality lecture. If you have questions, please post them in the discussion board. If you really need help, email me. If there's anything that I said that contraindicated what you learn in class, please follow the class and let me know, okay? I don't teach OB, so I'm not sure exactly what they teach. So if you have any contraindication, not contraindications, but you know what I'm trying to say. Any conflicts, please let me know. Okay. Thank you and good luck.